Well, good afternoon, everybody, and thank you for joining us today as we provide an update on the early days of the 988 rollout in Georgia. As many of you well know, just over 50 days ago, we took the first steps down a long road towards transforming Georgia's crisis system and making it easier for those experiencing a behavioral health crisis to know who to call in an emergency. So I'm really pleased as the commissioner of the Department of Behavioral Health and Developmental Disabilities to tell you what brings us here today. We made a commitment early in this process to being completely transparent with you in the planning process for 988. We promised to keep you all informed about the impact of the rollout of 988 on the people we serve and on our service delivery system. So we're here today to tell you what we've seen so far, because we know that 988 will have a tremendous impact on our service delivery system. And we want to share what we've seen so far and what we're going to be watching in the weeks ahead. So I have one important caveat as we start today that I want to be sure that you all understand. We're trying to strike a balance here. We wanted to tell you as much as we could, as quickly as we could. At the same time, it's very early in the data collection process, and all the information that we share today should be considered preliminary. So we know, first and foremost, that the way people are using this 3-digit dial may be making it possible for people who have been traditionally underserved to seek support more readily. So we're excited to talk about that. I'm also pleased to share, I think we're one of the first states to release this much information and data on the impact of 988 thus far. And we're going to continue to watch week over week how the information unfolds. And here's why. This is really important for us to understand who is seeking help, where we're successful, and where we need to prioritize our efforts to do additional capacity building in Georgia. Now, as I've said before, 988 is an easy to remember number for those seeking help for mental health and substance use disorder needs. And it's an incredible opportunity to reduce stigma for those seeking help. But it's also an intimidating challenge for states who are thinking about ways to build capacity to meet the growing need we see across this country. So in fact, many of you will recall that the early projections in Georgia expected that Georgia's crisis demand would double with the rollout of 988. And those initial projections were for the first year of the rollout. But a number of factors have changed since then, and I want to acknowledge those. Most importantly, our partners in the federal government made a decision that there would be no mass marketing of 988 until July of 2023. What you all know is we have engaged in targeted marketing towards specific high-risk groups. So all of that to say, it's too early for us to say how soon these projections may become reality today. But we do have a good story to tell about the initial rollout of 988. And that's what we're here to share with you today. So first and foremost, I'm excited to preview for you that Georgia is answering the 988 call at rates above the national standard. You'll hear more about this, but I want to take a moment and thank our partners in this effort, because that wouldn't be possible without the support we received from the governor's office and members of the General Assembly, understanding that we had to ramp up our capacity to have call response meet growing demand. So we're grateful for that. I also want to acknowledge our partners at the Georgia Crisis and Access Line. Those are the folks truly picking up the call, and they were able to ramp up and really meet the early expected increase in demand. You're going to hear a little bit more about the numbers there. The other thing I'm excited to share is that we do have early evidence that people we know need help, who have been traditionally underserved, are finding their way to support through this 988 line. So again, preview of more data that you're going to see. We're really proud of these early successes, but I want to be clear, we are very early in the process here. It's just the beginning of a long journey towards building capacity and walking alongside our fellow Georgians as we respond to the call for behavioral health crisis services. So I'm really pleased to let you know I've got our team of experts here with me today to share quite a breadth of information with you today. I'll be joined by Monica Johnson, as many of you well know, is the director of our behavioral health services here at DBHDD. And then we also have several expert members of our 988 steering team to share different aspects of the information. So we're excited to be with you today. Our commitment to transparency will continue. And I'm pleased to turn it over to Monica, who's going to start with some reminders about our partnership with the feds, what the national expectations are, and offer a preview of our early observations in this 988 journey. So Monica, please.
Thank you, Commissioner. So we can go to the next slide, please. So again, I'm Monica Johnson. I am the director for the Division of Behavioral Health here at the department, and I've been here with the department for almost 12 years. I'm excited to talk to you today about where we are right now on this very long but exciting journey. So just a table set or reset for some of you and table setting for others, I want to remind you the three key components of 988. The first component, of course, is someone to call. So this obviously is a federal law. It's not just specific to Georgia. This is happening across our country. And so in our state, we already had a crisis and access line for 15 years. We call that GCAL for short, and that line is still operational. And it's important to keep in mind that when we're talking about call volume, we're talking about the collective calls that came in either via 988 or via GCAL. The other piece of someone to call obviously includes texting and chat for our crisis and access line. And our center is open 24/7, 365 days a year. We also have peer-run warm lines that offer callers emotional support. These are staffed by individuals who are living a life of recovery. So that's the someone to call component of the 988 component. The second component is someone to respond. So once you call, that in itself is an intervention, but for some folks, they need additional support. And so that's where someone to respond could come into play. Someone to respond in Georgia could look like mobile crisis. Georgia already had, prior to implementation of 988, a statewide mobile crisis system. So we were able to piggyback on what we already had in place. So that still is an option, obviously, for someone that is needing a response to their crisis. We also have the ability to respond by coordinating with 911 or EMS as appropriate. And then, of course, we have the ability to respond by outpatient community provider response, which just looks like connecting the individual to an outpatient provider that is near them in their community or their geographical area. And then the third component, or the third leg of 988, is having a safe place to go for individuals that are in crisis and need care. This could look like any of the following things from this list that you see. Crisis stabilization units. In Georgia, we have 22 adult crisis units, and we have 4 child and adolescent units. We're very proud about that work, and we'll continue to seek to grow those type of community-based services. Crisis service centers, where an individual can walk in 24 hours, get a emergency assessment for their behavioral health crisis. Then we have peer wellness respite centers across the state. We're very proud of these centers. These are run by individuals living the life of recovery, whether that's mental health, addiction, or a combination of both. Detox and substance use disorder treatment, inpatient beds, and then crisis services that can be done in an outpatient type of a clinic setting or in a community setting as well. Next slide. So SAMHSA, our federal partners, have put forward a 5-year vision for 988. We have mimicked and basically adapted to the plan that they have set forward, and this is our goal as well. So goal 1, so there's 3 aims here. The first one is that 90% or more of all 988 contacts would be answered in state by 2023. So that addresses the someone to call, the first leg of 988. The second leg of 988, someone to respond. The goal here is 80% or more of individuals will have access to rapid crisis response by 2025. And then the third leg of 988, the goal here is around a safe place to go for crisis care. 80% or more of individuals will have access to community-based crisis care by 2027. This is important to share because this is where we are aligning our goals as well. Next slide, please. As you heard the commissioner preview earlier, you're going to get to see and hear some preliminary data. What I've done here is capture 4 kind of key points, but you're going to get a little bit more information throughout the presentation from my teammates today on each of these areas. 988 calls are being answered in 7.4 seconds on average, and 97% are being answered in state. We're very proud of this preliminary information. It's a good start for us. Georgia's rural counties have had the highest prevalence for crisis calls in the first 30 days of 988. You heard the commissioner say that the data is early. We don't quite know, in every instance, why is this happening? But we'll be using the next several months to dig further into this information and get a little bit more understanding about why some of this is even happening. In the first 45 days of the 988 rollout, we've had 476 calls that resulted in active rescues of individuals whose lives were believed to be in danger. And an active rescue, which will be referenced later today as well, but just for those that may not know, is if someone called our crisis center and they were in an immediate risk of harm either to themselves or someone else, and 911 would have to be dispatched, and our crisis center can make that connection with our 911 partners. And then the other point that we're seeing early is that approximately 10% of our calls were for youth under the age of 18. So those are some highlights of what we're seeing as we are entering, we're a little bit past now our first 45 days, but this is what we're starting to see. We'll be looking at this data very closely, looking at each component that you saw that's critical for 988 to happen. So without further ado, I'm going to turn this over to the next speaker, Anna Bork, to dig a little bit more into some of the data that we're seeing. Anna?
You, Monica. Hi, my name is Anna Bork, and I'm the director of the Office of Provider Relations and ASO Coordination. And I'm here to share first some data about how we're performing, and then I want to share some demographics data with you. Next slide, please. So just to share the weekly volume with you, this shows our weekly volume starting in 2019 and going through 2022. And because we do track our volume on a weekly basis, we're able to tell where our trends are, where we see spikes and where we see valleys over time. We know there's going to be a spike around Mother's Day. There's going to be a spike around the start of school. And we can see some spikes based on some natural occurring things such as natural disasters, or celebrity suicides also cause some spikes over time. But as you can see, we have had a significant increase in our volume since 2019 to 2022. Next slide, please. So in the first 40 days, how did we perform? How did we do as a center? The Georgia Crisis and Access Line and answering 988 calls was able to get to 988 calls in an average of 7.4 seconds. That's for just the 988 calls. On the overall call center, we were able to get to those calls in 14.8 seconds. So we're pretty pleased with that in terms of just being able to meet the standard for SAMHSA has set is that you would answer all calls within 3 minutes before it rolls back to 988. So we're pretty pleased with that answer rate. We're answering 96.9% of our 988 calls that come in, and we're answering 97.72% of our overall calls that come into the Georgia Crisis and Access Line in the last 45 days. Again, it's really early in the rollout. We will continue to monitor our performance and make sure that our response rates are continuing to meet our needs as the volumes increase, and we expect volumes to increase over time. Next slide, please. So what's the impact of the first 45 days? Well, if you compare the first 45 days of 988 to the exact same time period in 2021, you'll see that there has been a significant increase in call volume between July 16th and August 29th. And you see that a lot of that call volume increase comes from 988. The increase in calls coming to Georgia still majority come through the Georgia Crisis and Access Line, but we are watching the trend to ensure that as 988 implementation continues to be realized, that we're able to look at the impact and be able to continue to meet the need. Next slide, please. So the previous data is really about how we performed as a center. The next set of data is a 30-day data, and that is because this is based on demographics of what happened to the calls. So did we get to the calls? Yes, we did get to the calls. And then what happened? So in the first 30 days after rollout, we look at these calls in what we call an episode. Every call doesn't result in an episode. As a matter of fact, traditionally only about half of our calls result in episodes. People get their needs met without having to go into a full episode, which is where we would gather a lot of data. One episode may have multiple people calling. So just to let you know, this isn't episode data. And so what we found is that 30% of the calls are resolved on the call. We either were able to do a warm call, refer to a warm call, refer to outpatient. They were looking for information only. So 30% of the calls were able to be resolved on the call. 24% then needed someone to respond. And for us, someone to respond is both mobile crisis response and active rescue. Monica explained active rescue is when we reach out to 911 because there's imminent danger. And there's some more information later on about active rescue I'll go into. And then 46% of our people needed a safe place to go. And that safe place to go is our behavioral health crisis stabilization units and behavioral health crisis centers, or an inpatient referral to a hospital. Next slide, please. So where did the calls come? Next slide, please. I'm sorry. So where did the calls come from? So we track calls by counties in Georgia. Oh, no. Well, that's fine. So we track calls by, that's fine. We'll go there. By counties. And as you would imagine, for the 30-day period of 988, the majority of the calls actually came from the counties with the majority of the population. We had two counties that had no crisis calls. Whitman and Eccles County had no calls at all. 10% of our callers were outside of Georgia. And then we had about a little less than 10% who refused to give their location, and that is fine. We'll provide services to anyone. You do not have to provide information. You can remain anonymous and still continue to get services. Next slide, please. So this is the call volume. And you can see Fulton, DeKalb, Gwinnett, Cobb, Chatham,
Anna, we lost your sound.
The large in South Georgia. Now, it is really too early for us to draw conclusions on this. Am I frozen?
Anna, we got your first part of your conversation on this slide, but then you froze and dropped out. So you may just want to start with presenting it again, but your visual is still frozen. So thank you everybody for your patience as we're working through it.
Anna, do you want to start with county prevalence? I think that's where we cut off.
Can you?
Hey, Dawn, since we are losing Anna, do you mind picking up with the episodes by prevalence? Ryan, if you'll just skip us to the next slide.
Yes, thank you. That slide, there you go. Hello, everybody. I'm Dawn Peel. I'm the director of the Office of Crisis Coordination. And so in terms of the prevalence data, we saw that the majority of, not the majority, but the cases, the counties with the highest prevalence were some of our rural counties. And as you can see, many of those were in the southern end of our state. So again, as we've said before, this data is preliminary. We are looking, we're going to continue to look at it. But for the first 30 days, there were more cases in South rural Georgia than other parts of the state. One of the interesting things to consider when you think about rural rates is that in 2020, the rural suicide rates increased by 8.3%, while they decreased to some degree in urban areas. So just an interesting piece of information as we continue to look at this data and consider what it means as we move forward. Next slide, please. This has a bit of easier to see breakdown of the counties with the highest prevalence rates. I got a little bit ahead of myself, I apologize. Rural South Georgia obviously was higher than their urban counterparts. And in Webster County, people reached out at twice the rate of the number of people that reached out in Fulton County. So again, we'll continue to monitor this as we move forward with our data analysis. Next slide, please. So this slide focuses on crisis episodes by gender. And again, preliminary data, we'll need to dig into this more. But what we know nationally is that males make up 49% of the population, but nearly 80% of the completed suicides. During the first 30 days of the rollout here in Georgia, as you can see on the left, males comprised over 53% of the calls to GCAL. And so some of that might be because men are less likely to reach out in typical outpatient services and maybe more inclined to reach out to an anonymous hotline. But you know, it's interesting to see that has happened as time has gone on. Next slide, please. This focuses on crisis episodes by age. And some interesting information is that emergency room visits for youth and young people grew by 24% for youth ages 5 to 11 during the pandemic, and by 31% for youth ages 12 to 17. And that's information that we got from the CDC. In the first 30 days of the rollout, just under 10% of episodes were for youth under the age of 18. So that includes both youth that called in for themselves and people that called on behalf of youth and young people. Next slide, please. As we think about crisis episodes by race, we can see here that approximately 27% of the calls were from white or Caucasian people. Just over 30% were from Black or African Americans. And then there were a number of people that were unknown or unreported in terms of their racial information. Again, some interesting information is that since 2020, suicide attempts and deaths by suicide for the African American population have increased. And in 2019, suicide was the leading cause of death, the second leading cause of death for African Americans aged 25 to 14. So that kind of speaks a little bit to that information we saw in the last slide as well. Next slide, please. So in terms of a key trend to watch, we're going to shift our focus a bit. When we think about active rescues, in FY22, the average number of active rescues per day was 8.5. And again, just as a reminder, when we talk about active rescue, we're thinking about situations where the call center staff have significant concern about the immediate health and safety of the individual that's calling or the individual that's being called about. And so they then link that person to a 911 center to trigger an EMS or police response. So I got a bit ahead of myself with the data, I apologize. So in FY22, 8.5 average number of active rescues per day. And in the first 45 days of the 90-day rollout, that number increased to 10.5. Again, this is preliminary data. We'll continue to monitor this, but we are considering what that might mean. One of the thoughts could be that people that typically call the National Suicide Prevention Lifeline prior to 988 might not have been calling in a suicidal crisis. They might have been calling for another reason. And so the name of the lifeline has changed to the National Suicide and Crisis Lifeline. So that could account for some of the increased, the increase in the concerns about people that were at risk of harming themselves or others. But again, we're going to continue to watch this as time goes on. One thing I want to mention before we move on to the next slide is that as GCAL has typically been used as the no wrong door approach for information, the Lifeline calls and the 988 calls might have more people that are in significant need, as I was just alluding to before. And those people might have an increased need for active rescue. One additional point of context with this information is that the Georgia Crisis and Access Line gets on average about 800 calls a day. So as we think about 10.5 active rescues per day, that number is a very, very small proportion of the overall calls that are coming in every day. Next slide, please. So we're going to shift now and talk about mobile crisis teams and their dispatches. So mobile crisis teams are dispatched when there is a need for on-site crisis management, and those services include evaluation, de-escalation, consultation, and referral to either outpatient services or inpatient services. Our teams work really hard to determine what is the least restrictive level of care for that person that will be safe and appropriate for them. And those services that will meet their needs. So over the past 4 years, the number of mobile crisis dispatches has increased by 37%. And in the first 30 days of the 90-day rollout, there were over 1,900 mobile crisis response dispatches in Georgia. Our federal projections suggest that mobile crisis dispatch, the demand for those services could increase by as much as 176%. But I do again want to remind you, as Commissioner Fitzgerald mentioned, those projections were based off information that involved mass marketing of 988, and we're not doing that yet. So again, we're continuing to watch the percentage of increase for demand and planning as we watch that demand increase. Next slide, please. Shifting our focus to community crisis referrals. To begin, I'd like to just remind, thank you. I'd just like to remind people that community crisis beds are inclusive of our crisis stabilization units, behavioral health crisis centers, and referrals to state-funded inpatient beds. So during the first 30 days of the 988 rollout, there were over 4,100 community crisis bed referrals. The federal projections suggest that our need for community crisis beds could increase by 105% during the first year of 988 implementation, where there is that national mass marketing as well. What that means for Georgia is that we would need to increase our community crisis capacity by 500 beds or chairs. And that increase is inclusive of both child and adolescent crisis stabilization beds, adult crisis stabilization beds, and temporary observation chairs for adults in our behavioral health crisis centers. One thing I'd like to mention is that our community crisis beds rely very heavily on nursing staff to provide coverage for those different service areas, both the inpatient beds, the behavioral health crisis centers, and our crisis stabilization units. And so that the workforce shortage has hit those units hard to some degree. And we're working hard with our partners to identify ways ways to improve the workforce development for nurses and other staff participants that support those units. I do want to mention that we've received some investments to strengthen our crisis staffing in our community crisis beds, and we're very grateful for that support. We are also grateful for other investments that have come up or other programs that have been put into place to allow tuition reimbursement and other types of things to help supplement our workforce. Next slide, please. So before I turn it back over, I'd like to highlight some common frequently asked questions and misperceptions that have come about with the rollout of 988. So the first one that has come up quite a bit is, what's the difference between 988 and 911? And so when a person calls 911, the dispatchers typically gather information from the caller, make a determination about the next steps, and then they typically dispatch fire, EMS, or law enforcement, or a combination of those. When a person calls 988, the call is answered by a trained counselor who talks to the person, assesses the situation and the person, and attempts to de-escalate the person whenever it's appropriate, and then makes appropriate determinations for the next steps. With 988, the call to 988, the call center, is often the intervention in and of itself, and will result in a person being linked to outpatient services. In some cases, they need to dispatch mobile crisis or refer a person to an inpatient bed. But in many cases, the call itself is the intervention. Another difference between 988 and 911 has to do with the response time. So the national average for response time for emergency medical services is 7 minutes. And when we think about a 988 call, the phone call on average can take 20 minutes because of the things I just mentioned, all the different types of information that's being gathered, as well as all the different de-escalation and referrals to next steps in terms of appropriate levels of care. If mobile crisis needs to be dispatched, it's important to understand that they are not like EMS or law enforcement. They do not come respond with lights and sirens. And so that response might take longer. Our goal for mobile crisis team dispatch is to arrive within 60 minutes of being dispatched. And so I take some time and focus on the difference between 988 and 911, because I think it's important to have some level setting and for people to have expectations, realistic expectations about what typically happens when someone calls 988. The next point I want to focus on is another frequently asked question. Will law enforcement still be dispatched if I call 988? And so there's a lot of misinformation out there on social media about this. So I think it's an important area to focus on. Our goal with 988 and our call centers is to have law enforcement dispatched only when it's absolutely necessary. When we talked about active rescue earlier, in situations where an individual is in very imminent danger of risk to themselves or others, those are the situations where the 988 call center staff person would link that person back to 911 so that law enforcement could be dispatched. It's done as a last resort, and the information that's shared with 911 is only the information that's needed to ensure that person's safety. And as Anna mentioned earlier, on average about, Anna didn't mention, I'm sorry, I mentioned it earlier. About 10% of active rescues occur per day per 800 calls per day. So again, it's a very small percentage of the calls that come in through the Georgia Crisis and Access Line and 988. The next frequently asked question is, what happens when people call 988? And will they be involuntarily committed if they reach out for help? Again, there's a lot of misinformation about this on the internet, on social media, and I think we have a good opportunity here to dispel some of those myths. So the fact is, 1% of all calls in Georgia that come through the Georgia Crisis and Access Line, whether it's through 988 or whether it's through the typical Georgia Crisis and Access Line number, result in a 1013 order when our mobile crisis teams are dispatched. So 1% of people that call and get a mobile crisis response are resulting in a 1013 or an order for an involuntary evaluation. As I shared earlier, our teams work really, really hard to find any other option that is safe and appropriate for people, as opposed to an inpatient facility or an involuntary evaluation order or a 1013. There are times when mobile crisis goes out and does an evaluation and can de-escalate the person and refer them to outpatient services. In some cases where the individual needs further evaluation at an inpatient facility, oftentimes those teams can talk the person into going voluntarily, which is always preferred. And only in those cases where the person will not agree to go voluntarily and they're at imminent risk to themselves or others is when a 1013 would be written. The next question, can I text 988? That one comes up a lot as well. The short answer is yes. People can use 988 to text or chat. But the way that it is structured now, those texts and chats are currently routed to behavioral health professionals outside of Georgia. Our teams are working very closely with our national partners to have those 98 calls routed to Georgia clinicians, but we're not quite there yet. So if you want to text and chat and want to be connected to a clinician in Georgia, please use the MyGCal app that's available for Apple, iPhone, and Android devices. And then the last question, does 988 have geolocation capability? And at this point, we cannot geolocate. We can't identify where a person's calling from when they call through 988 or the Georgia Crisis and Access line. One thing I should mention, though, is if the individual is at imminent risk, like we've talked about earlier, and they need a law enforcement response, they would be connected back to 911, and 911 centers do have geolocation capabilities. So that's oftentimes a very important caveat that I think sometimes gets missed. But at this point, 988 does not have geolocation capabilities. So if you're looking for answers to more frequently asked questions, please go to our website, 988ga.org. And at this point, I'm going to turn it over to Wendy for our question and answer period.
Hi, everyone. I spoke to you briefly earlier. I'm Wendy White-Tygreen, and I know so many of you, and I'm so glad that you have joined us today. I serve as the director of the Office of Medicaid Coordination and Health System Innovation for the department. And we are going to jump into some question and answers from you all as participants on the call today. So please feel free to use the Q&A function at the bottom of the screen. You see the icon that has Q&A listed right under it. Please feel free to type in anything there, but I'm going to go ahead and say that I've screened some of the initial questions. We've been answering a couple live, but we're going to go ahead and jump into the ones that have already shown up in that function. And I'm going to kick it first to my colleague Dawn. And we are going to talk a second about a question that we have related to transportation. So one of our callers was interested in how transportation might work related to mobile crisis or subsequent need for transportation post a mobile crisis intervention.
So thank you, Wendy. That's a great question. So when our mobile crisis teams respond and a person needs to go somewhere else for evaluation, they work very closely with any natural supports that might be there or anyone else that can be there to assist in getting that person to the facility where they need to be. In some situations, there is the need to collaborate with law enforcement, particularly in situations where the individual is extremely agitated or cannot be transported safely in any other way.
Thanks, Dawn. And then Anna has made her way back to us. So she lost her internet coverage completely there momentarily. So to our folks who are participating online, who we lost Anna, she's back. And want to just speak quickly to a question, Anna, that came in when one of the participants heard you mention, for instance, the spike that happens generally when school begins. There was a question about whether or not the caller is an adult or if it is actually the young person who calls. So would you like to field that, please?
I would be happy to. First, I want to thank Dawn for stepping in and covering for me when internet decided it didn't like me anymore. And then I want to apologize to those on the webinar because I'm not going to turn back on my camera because I don't want to tempt fate. At this moment, I'm here and we'll be happy to answer that question. It is the spike when school starts what we capture is the age of the individual, so we can't verify 100% without some more data analysis, but it is from anecdotally, it's schools calling. When the kids go back to school, teachers call, social workers call, and those sort of things. But again, we only capture through the episode the age of what the individual the call is about. So does that answer the question, Wendy?
I think so. Without follow-up, we'll check in Q&A if there happens to be any follow-up, but thank you for that, Anna. We have had kind of a generalist question. 2 or 3 of these have come in about access to the slides. And I will just go ahead and share that post this presentation today, and post most presentations that we are making related to 988. We are using the 988ga.org website to post all of that information. And so previous presentations are accessible there as well as this one. So we encourage you to use that, and we'll come back to that in a moment and talk some more about that. So we have another conversation, question about whether or not there is targeted outreach related to those with limited English proficiency or some unique cultural linguistic presentation who might need crisis services, and how we are addressing and planning around that work. So Anna and or Dawn, or if not, I can take a stab either way. Do you want to go ahead and jump in first?
Thank you, Wendy. I don't mind jumping in. So I appreciate that question. I think it's a very pertinent question to address. And it's something that has come up with some of our community work that we've done with some of the partners we've engaged in the community. So we're working to translate our website and the documents on the website into Spanish, as well as have a link to the SAMHSA website that has the capacity to translate that information into a number of other languages. Anna or Wendy, if there's anything else you'd like to add, please feel free to weigh in.
I will just share, we have a fabulous group of leaders that are part of a work group, the partners, who are providing us guidance and leadership related to some really targeted niche areas of risk and vulnerability for the population, as well as individuals who represent different cultures, ethnic, racial groups, who are very important to all of the work we are doing. And they continue to provide us great resources and advisement. And so we continue to learn from them every time we are able to be together and to try to implement the recommendations that they are making on this very important body of work. So I say thank you for all of you who I see today who are those community partners. And we continue to meet more and more individuals who we want to include greater learning so that we are best prepared for responding to all Georgians. We've had a question about the credentials of the individuals answering the calls. So Anna, if you don't mind stepping back in for that response.
No worries. For 988, anyone answering the call to the 988 goes into a queue where only a master's level behavioral health professional answers those calls. And those calls are then supervised by a licensed professional. So it's a master's level mental health professional supervised by a licensed professional. They are also all trained in the Columbia scale and in, I say it wrong every time, it's locus, not lotus, locus, which is also an assessment and have special training in working with individuals in a crisis.
Thanks, Anna. Dawn, I'm gonna pivot to you for a moment. And some folks, there's just a real generalist question that I think is helpful, but a participant just wants to know a little bit more about mobile crisis teams. For instance, are they statewide? Are they state employees? Are they vendors? So if you just want to do some real generalized comments to that. And then I will just remind folks again, our historical content and presentations where there is a little bit more of this detail are on that website that we provided a moment ago.
Yes, thank you, Wendy. So our mobile crisis teams are contracted. They're employees of agencies that are contracted with DDHDD. And so they're not state employees, but we do work very closely with the providers around, focusing on things like training and those types of things. Trying to think, I've lost if there's another part of the question.
Dawn,
Okay.
there's a specific follow-up on that is, are they administered by law enforcement?
So our mobile crisis teams are not typically administered by law enforcement. Thank you, Wendy. There are some municipalities that have co-responder teams in place. And those are different than our mobile crisis teams, but in many ways do similar work because they're able to respond on the scene. Co-responder teams typically have a member of law enforcement or EMS and a trained mental health professional. And so they do similar work, but they're not the same entities.
And then one more, Dawn, if you don't mind, just talking about the nature of the general nature of a mobile crisis response, like 2 practitioners and the mix of that.
Sure. So our mobile crisis teams, as Wendy alluded to, have 2 people that respond so that, we can ensure safety and also for the skill sets that different people have. There's a clinician that responds that is responsible for the assessment and doing those types of things. And then there's a paraprofessional that responds as well. In many cases, that paraprofessional is a certified peer specialist or has another type of a certification, a CARES certification, somebody that has lived experience. And that's really important because in a time of crisis, engagement and hope for recovery is really, really important. So the teams do a really good job of having both the assessment piece and the engagement and de-escalation piece there as well.
And then I think in general, Anna already responded to the types of practitioners and the range of individuals who answer the calls. But we had another question about peer role in general. And so Dawn, you kicked that up nicely. I think Anna referenced that there are some individuals who are certified peer specialists who are trained, who field some portion of response in the Georgia Crisis and Access Line. And Dawn just spoke to peers in mobile crisis teams. And then I think the one other area is in our crisis stabilization units. Many of them also, and our crisis service centers, many of them also employ certified peer specialists on their teams so that we are offering the lived experience lens as often as we can in these very vulnerable and critical times of an individual's crisis. So Anna, is there anything else you want to add to that?
Yeah, so we are working with and do transfer to the Peer Center warm lines also. And we're working with how we can do that in a more, just looking at how we can do that more.
Exactly. We have a question about an estimated response time related to mobile crisis. So what is kind of the estimated response time at this point?
So I assume you probably want me to jump in for this one. The question I have is the estimated part. That's what I really don't understand. Because when a mobile crisis team is dispatched, they will reach out to the person that made the call and let them know when they expect to arrive on site. So it really differs with each call. One of the things that we know is that we're working to increase capacity within our mobile crisis teams in line with that goal that the federal horizons that Monica mentioned earlier of making sure that we have 80% or more of rapid mobile crisis by 2025. So I hope that answers the question.
Thank you. And then one other question is about when there may be more data in the future and when we think we might have enough data to draw some more conclusions. So I think this might be a good way to begin to pivot to our wrapping up of this session. And so Commissioner Fitzgerald, I will go ahead knowing that you intend to just speak briefly about that and what's ahead.
Yeah, thanks so much, Wendy and team. And thank you to participants with smart questions who are following along closely. A couple of things I want to say. First, and many of you have heard me say this before, DBHTD doesn't do anything on its own. So I see that many people on the line are partners and providers who are walking right alongside us in this effort. And I just want to say thank you and acknowledge your contributions. We have members of our planning committee who are here as well. We continue to get the advice of those who are seeing the work on the ground, and we are going to continue to do that. So a couple of things to be clear. Our commitment to transparency is real and lasting here. We're going to be excited to keep coming back to you with the data about what's happening all across the state. And we're going to be really thoughtful and strategic about how we build capacity based on that data. So the cautions you hear today are just that commitment that we make as stewards of really important resources, that we want to make the right investments to be responsive to our families and communities in Georgia. We're going to continue to do that. We're getting a first look at a lot of this data right now. So y'all are asking good questions. We ask you just be patient with us as we try to dig deeper, especially into some of that demographic data, and really get a better understanding of what it's telling us about how our system is performing. Now, to be clear, this website, the PowerPoint, this webinar and the PowerPoint will be posted to the 988ga.org website. The other thing that we committed to do is, as you've asked questions, we post them on the FAQs there. So this is a constant learning environment, and we're going to be partnered with you in learning together as we do this. So I want to thank you all for joining us today. Let you know that we absolutely do expect we'll have more public information before the year is out. Again, when we have meaningful information to share, and we want you to see that, we are going to use that website. So always go back to the website and know that we are committed to share data and information with you, and as best we can tell you what the strategies for being responsive here in Georgia are. Again, I just want to thank you all for participating. Thank you for your good questions. And we look forward to staying in this important and life-saving and system-changing work with you in the future. Thank you, everybody.